And here we go. Good day, 17:30 South African time, and welcome to the last in our series of 3 webinars on promoting healthy body image and the sexuality in pediatric cancer patients. As previously said, my name is Audrey Ludig. I'm the Program Development Manager for Childhood Cancer Foundation, an NGO in South Africa. And our mission is to support children and teenagers with cancer or life-threatening blood disorders and their families. We try to improve early detection, and we support effective treatment, and we are a support organization to the pediatric oncology units in South Africa. So welcome to this webinar. During different focus group discussions and individual conversations with long-term survivors, it became clear that one of the many struggles they experience is a healthy body image and sexuality. And therefore, we decided to host these 3 webinars to address this very sensitive topic. During the first webinar, we spoke about fertility and sexual aspects in pediatric oncology patients and long-term survivors. We had 3 wonderful experts from the Princess Maxima Center for Pediatric Oncology in Utrecht in the Netherlands. And Dr. Helene van der Pol spoke about the late effects of childhood cancer on fertility and sexual problems. Irene Igoshi is a nurse practitioner in oncofertility, and she spoke about the possible effects of childhood cancer on sexuality. And then Dr. Mariana van der Wetering shared all the new trends and developments in fertility. And then we had our first survivor who spoke, Zuki, and she shared with us her wonderful story, how she became a miracle mother. And then in our second webinar, we had 2 long-term survivors who spoke. Jenna Dahlman spoke about her fertility issues and how important, and she asked me, how bluntly could she speak about communication? And I said, you can call a spade, because we need to talk about this issue. And she said, honest and communication is very important between the medical team and the patient. And then we also had Danica Henman, also a long-term survivor, and she shared with us her challenges with a sexual image post-treatment. Mandy Rodriguez, a clinical psychologist and a life coach, shared with us her personal journey with cancer and her professional expertise on fertility challenges and beyond of cancer patients. Now, if you missed any of these webinars, please, you can still catch them on YouTube, and please share it with your friends and colleagues. We can all learn from each other on the discussions and the wonderful presentations that we were able to listen to. Now, today, if you have any questions, please put it in the chat, and we will see how we can address these questions either during the conversation or afterwards. But please, not one question is unnecessary. Something that might feel to you it's not really worth asking. You know what, that question could mean a lot to another survivor and could really have an impact in their lives. Now today, we are going to go into conversation with 2 survivors, and then Dr. Sage Balte from Fairfax in Virginia, we're so privileged to have all the way from America, will be our keynote speaker. I was very privileged to listen to her at SIBE conference in Lyon in 2019, and I can assure you her talk is not to be missed. So without any further ado, our first speaker today is Steven Slotow. So Steven, he's now 41 years old. I've known Steven for many, many years. He's been very instrumental in the survivors group in Johannesburg for many years. Was diagnosed with a malignant teratoma of the spinal gland at the age of 11. So due to the position of the tumor on his brain, Steven was fortunate enough to undergo a surgery, and then 1 year later, chemotherapy and radiation to cure the cancer. And his words is, thank God, since then, I had no relapse or recurrence of cancer personally. So Steven has been in a committed relationship and with his girlfriend for over 12 years. And Stevie, I've never met her. That's a shame, eh? And the couple have no plans of getting married immediately, but have now started the conversation. You know, they think of getting married and they think of possible starting a family. And this is something that they are considering in the near future. And I think that might be an interesting conversation. So, Steven, I'm going to start by saying welcome to the conversation. And good to see you. Do you have any long-term effects post-treatment?
Thank you, Audrey, for the intro. It's nice to be here. It's always nice to chat to you and meet new people in the world of childhood cancer. Yeah, thank God. You know, in terms of knock-on effect or post-treatment implications in my life, I've been very fortunate. You know, I think my cancer journey has been one of real fortune. I've always said, you know, one of the biggest lessons I learned is that it could always be worse. You know, I looked around in those days and I always considered my family and I consider myself so fortunate that we saw such terribleness around us, so many people in such grave situations that whatever we got, as bad as it was not as bad as we felt other people going through. So it's pretty much been the same post-treatment as well. You know, thank God I haven't had a lot of knock-on effects. I've had a few scares over the years in terms of headaches and migraines and things like that, but thank God everything's been clear. And even the treatment itself, while it's pretty dramatic and pretty poisonous during the actual treatment, thank God after, you know, I kind of got through it and with as little impact physically on my life as I could have hoped for. So I've been lucky in that way.
That's wonderful. You are definitely more privileged than most of our childhood cancer survivors, especially in low-income countries where they are diagnosed at such late stage of the disease. Stephen, has anyone ever spoken to you about fertility post-treatment?
No, it was actually interestingly so. I think also, you know, I'm kind of unique in the world of childhood cancer. I've always thought I was unique in the world of childhood cancer in that I was diagnosed quite late in childhood. I was 11 years old when I was diagnosed. And again, I always consider myself lucky for that as well, because I was old enough to know and be conscious of what was going on around me and take it in and deal with it, deal with what my family was going through, deal with what I was going through personally. I watched, you know, a lot of the people around me that were getting diagnosed were the babies and the toddlers and the kids, the really young kids, who didn't have a full understanding of what was going on. So I was able to take in a lot of what was going on around me in that time. And at the time, the one thing that one of the things that didn't come up was that question about, you know, fertility or the future of kids and things like that. The first time that it came into my recollection was I was about 18, 19 years old, and my mom, who was obviously there for me during the early days, 11, 12 years old, while I was going through treatment, my mom mentioned something to me about, you know, the doctors mentioned it, but, you know, I was 18, so it wasn't really something that I was considering at the time. It was only recently in the last couple of years when I've been talking to my mom about, you know, and my girlfriend about, you know, kids and family planning and things like that, that my mom first brought it back up to me and said, you know, when you were young and when we were going through this, the doctors did mention that there could be a potential implication on your ability to have kids. They didn't decisively say you won't be able to have kids or you will be able to have kids, but they did mention that this is something that we will need to consider in the future. So that was kind of the first time that I can remember. It was only a few years ago. And at the time, my mom was very apologetic about it. She felt terrible that she hadn't forewarned me or brought it up in so many years. which I thought was pretty crazy, considering it's my mother who, you know, I owe my life to based on what I've been through in my life. So there were no hard feelings about it, but she was very apologetic, and it was something that kind of slipped her mind. The way that she put it in terms of remembering back was, you know, there was so much going on, and there was so much concern, and there was so much worry, and there were so many balls to juggle, that it was just something that she didn't concern herself with until much later on. So she felt very bad about it, and I put her mind saying, you really didn't have to feel bad about it. There's nothing she could have done anyway. So it's just that she felt bad that she hadn't given me the heads up or reminded me that this was something that would be a consideration.
I think that's one of the biggest problems with most of the patients, that first the medical team, and secondly the parents don't have the courage to speak to their children. I think maybe because they don't know what to say to them, and you know, and the uncertainty of the future. Maybe it's fear, but I think we need to overcome that by starting the conversation. So in that, have you and your girlfriend ever spoken about family planning should you get married?
Yeah, we have. I would say something about what you just said first, actually, and just say I agree with you wholeheartedly, is especially with childhood cancer. I think I'm thinking about, obviously, from a personal perspective, so it's anecdotal, but I think from a personal perspective, I was 11, 12 years old. By the time I was 13, I was clear of, you know, I was off chemo and I was off radiation, and I was in the, you know, recovery, and I was going to every 6 months CAT scans and things like that. I do believe fully that what you've just said is spot on. If at the age of 11, 12, 13, and as I say, I think that's quite old for childhood cancer. I remember at the time they wanted to actually put me in the adult ward because I was a bit older, and the doctors, Dr. Khan at the time, fought them, and you know, there was a whole thing about it because, and I'm very grateful to this day that I landed up in CHOC. But I was 11, 12. I was a little bit older. So as I said, I could fully understand. And if the conversation had been had with me at that stage, I could have fully taken it in and understood it. And at the late age of 11, 12, 13, I wasn't thinking about having kids. It obviously wasn't something on my mind. But I think it would have been helpful to have had that conversation then, just so that it prepared me. And I feel like even for a younger kid of 7, 8 years old, if it's a conversation is delicately had with the kid, and explain to them that this is something that may impact their ability to have children of their own at a later stage. At the very least, you're planting seeds, and you're preparing the foundation for them to consider that from a young age. And I think it would be much better for the kids if they are, you know, I've always said this about childhood cancer kids, and Audrey, I think it goes to what you were saying right now about we've got to have the courage, and we often don't know what to say. I've always said this about cancer kids, and I'm sure Spunky is the same, because she's been there. We don't give the cancer kids enough credit for what they're capable of understanding and doing. The hardest children in the world are kids who've got cancer. They are the strongest, the most brave. You know, they are real heroes. And I think from even the tough conversations, like, hey man, got to tell you that this might impact your ability to have kids in 30 years or 20 years or whatever it is. I think we need to give kids more credit so that they can understand. But of course, it's got to go on a case-by-case basis, and some kids won't understand it. They won't get it, and they won't want to have that conversation. But I think we need to give the kids a benefit of the doubt and have the conversation with them. We as the adults need to be brave, because the kids are already brave. They already know they already have all the courage. And we all see this every day in the cancer wards. But we as the adults need to, you know, grow a set, as it were, and actually say, hey man, this isn't going to be an easy conversation, and I don't know how to say this to this kid, but I need to do it because it's for their benefit in 20 years' time. Let me put it on the table. I think it's a very, as I say, as I've always said this, we don't give those kids enough credit for what they can handle. Sometimes telling a kid that they're going to lose their eye, or we're scared to do it, or that their cancer is deadly. That was told to me. It was a very dangerous cancer. I'm glad they told me that. I didn't fully appreciate how dangerous it was, but I'm glad they told me, because at least I knew what I was up against. And I think it's an important thing that we can get, we can hand over to the kids to deal with. So
your girlfriend, have you spoken to your girlfriend about fertility?
Yeah.
Have you discussed family and things like that?
We have discussed it a bit, and obviously this was a concern. This was a concern that we both had, and I got checked out, and thank God everything is okay, and I am able to have kids. It was a concern, you know. I think when they do a fertility test on men, I'm sure it's pretty much the same with women, but they like to cover their bases and say, yes, everything looks okay. This isn't a guarantee that you can have kids, but there's nothing that we can see that can stop you. So thank God everything's fine. Yeah.
That's fantastic. I hope one day you'll come and show me your kitty. Maybe I'll be the grandpa. What is your message to men post-cancer treatment regarding body image and the sexual self? Some patients, remember, have problems, but what would you say to them? You've already said so beautiful things. Yeah, I nearly had me in tears, but what would you say to men specifically, boys and men?
You know, the reality is, it's a great question, and I don't have a silver bullet kind of statement to say. The reality is, I've dealt with my own body image issues over the years. I'm quite a short person. I was born, I think at the time they were saying, you know, the tumor could have stunted my growth, and I'm quite a short person, and I've dealt with that my whole life. Obviously, you don't grow any higher than you would, and there's nothing I can do about that. So I've dealt with that body image thing, and the reality is that one thing that I've learned, and I learned this, you know, when I was going through cancer at a young age, 11, 12, 13, I was just dealing with life. You know, we were just going through what we needed to go through. And as you hit puberty and as you start getting a bit older, you start realizing the reality of the situation is you become insecure, and you go through all the stuff that teenagers go through. When I got into my 20s, got into my 30s, I reached a point I would say to men is that, and it's a hard thing to say to someone that you can't force them to understand, but if you can get it through your head and understand that even though you've been through cancer, even though you've got this potentially a disfigurement potentially, or you've got a stunt or something like that in your growth, or whatever it is, the good news is it's not good news for humanity, but it's good news for you, is that everybody is self-conscious about something. And even you as a cancer survivor, your self-consciousness might be something really unavoidable to see. It might be worn on your face literally, or it may be something, you know, that really is hard to overlook. The good news is that, trust me, everybody's walking around with exactly the same kind of insecurities that you've got. They may be insecure about their weight, they may be insecure about their hair, maybe insecure about their heart, whatever it is. The good news is that even as a cancer patient, at the end of the day, you're just a normal human being. And if anything, you've got a phenomenal story to tell. So that should be something that you should wear as an armor to say, hey, I've got this disfigurement, and actually, here's the story. And you should be proud of it. Try as your best to be proud of it. It's not easy to do, but try your best to be proud of it.
Thank you, Steven. That was so powerful.
Yeah.
I think love yourself and love your body. I mean, I'm in my menopause now. Sometimes I think, oh, where's this going to? But you know what? You love yourself, and that is what we need to do. Because if we love ourselves, it will be easy to love our partners and to carry ourselves with that confidence. Steven, don't go away. I'm now going to speak to Sarah, but we actually know her as Spunky. Spunky, welcome. I'm so glad to see you again, also known Spunky for many, many years.
Yeah.
Spunky is, we know her as Spunky by our friends, family, CHOC, the childhood cancer environment, and never was a name fitted a person better than that. At the very tender age of 8, Sarah wrote a book. She wrote it with the help of her mother. So she had the words, and her mother wrote it in the book. So Nicky gave her mother's name is Nicky. Nicky gave the medical understanding of the terms, or the understanding of the medical terms, and did the initial edits. But it was Sarah's words, or Spunky's words. And Spunky, I read your book. It was so beautiful, so powerful.
Oh,
and in your book, you share your journey of becoming a cancer survivor and against all odds, a provincial badminton player. So welcome, Spunky. So I want to ask you, you were diagnosed with Ewing sarcoma, and one of the side effects of your treatment was that your one leg was 6 centimeters shorter than the other and had to be lengthened. Tell us about your journey at 19 years when you had to wear a Elizarov frame for a whole year. And you told me a very nice story, or not a nice story, but you told me, I hope you're going to share it.
Thank you so much, Audrey. Thank you so much. I appreciate being here. And Stephen, your story is just so inspirational, and I fully agree with everything you were saying. Yeah, so at the age of 19, I needed to get my leg extended because then I was finally done growing. We couldn't do it while I was growing, else it would just kind of grow at a discrepancy. So it needed to be done when I was fully done growing. And we all sat down as a family and discussed if it's actually worth doing this, because it's a huge operation. It took many, many hours, and it includes having an huge external metal frame, and you can see into your leg, and there's a lot of pins, and it's very gruesome. And then we sat and discussed, is it the best thing to do? We came to the decision of, we can only try, and I'm so happy we did. I mean, my leg was 6 centimeters shorter for 11 years of my life. My foot is underdeveloped. My knee is underdeveloped because I didn't walk properly, because it was 6 centimeters shorter, and I would build up my shoe with these thick metal corks that was so expensive and so heavy, that I was just so grateful to not wear, I would call it the shoe because it was kind of only 1 or 2 of them. And I was so grateful to not have to wear the shoe again, just so that I could walk normally. And I mean, I became so self-conscious about my shadow. It's something that is so simple that no one even thinks about. To see my shadow doing this as I walk, as a kid growing up, I remember that insecurity. And now I've completely changed my approach on it, and I quite enjoy what I see there now. So it takes a lot of growth and personality and acceptance to get there. Yeah.
Yeah, and you told me once that you were at a party and there was this, you were wearing a dress and this very sexy young man came up to you and started to chat you up, and the next one he saw your leg and he got up and walked away. How did that make you feel?
In the moment, it made me feel very upset, but on the inside, it's not really something that comes on the out. But I felt very insecure, and I was like, look, I know that I'm different, but is it a bad thing? Is it wrong to do that? Am I repelling people? And I even had my cousin who, I mean, I've known my whole life. He came to me and said, I'm sorry, I just can't come and visit you because it's too gruesome to look at. I mean, you can literally see the pin in my leg, and that made me feel a bit insecure. But I do understand from their point of view as well. I can't watch the news. Sometimes it just upsets me too much, and I need to do that to protect my peace. And that's exactly what those people did. So I've come to that understanding of it. Yeah.
It's such a strong role.
Do
you have any fertility issues post-treatment?
I do, yeah. So my ovaries and my organs and my leg, and actually all the way down to the bottom of my leg, which we discovered later, is all damaged from the radiation. So I had to obviously go to the gynae to see, what is the situation with me wanting to have kids in the future. So I did that when I was 19. And they said, look, you will only know when the time comes, because it can get easier and easier and better, and eventually you might have kids. But when I was going through my treatments already, they told me, and I'm sorry, Stephen, that you didn't get that opportunity, but I'm grateful that I was told that, yeah, you have a lot of radiation damage and you might not be able to have kids. And I knew that from the get-go. So when I got to 19, I went to the gynae and they said that you might struggle, but when the day comes, let's chat. And I quite recently went back and they told me that everything is looking good. It's all healthy and I will be able to have kids. The only problem is I must do it before the age of 35. So I still have enough time to go about and get that done. And it is something I've always wanted my whole life. So I'm just so grateful that I can have it.
Yeah. Well, I pray that you will have that wonderful miracle in your life as well. Like Suki, everybody said it is against the odds, but you know what? She got a little baby, and Zoe is now 11 years old already, and
Wow.
the beautiful little young girl.
Yeah.
The fact that you have multiple scars on your leg, and the possibility that you might not have, well, now we say that we hope you will have kids. Does that have any influence on your sexual self and your body image?
Yeah, definitely. I used to be very insecure whenever it came to that kind of, when you come to that moment when you become so intimate with someone and they do get to see your scars. I've never ever had anyone say anything bad about them, but I myself was always someone who expressed the insecurity first, got that out of the way so that I didn't have to feel worried, but it always bothered me. And not until quite recently did I actually grow past that. And now I'm like, well, you know what, that's what it is. It's not going to affect my relationship with you, and it's not going to change anything. And it's just taking acceptance. And I know that the right person or whoever I'll end up with, they wouldn't need to have a problem with that, because it won't be about that.
Won't be about the outer body, it's about the inner body. And that
Yeah, exactly.
Beautiful, beautiful inside and outside. And I wish you everything of the best for your life.
Oh.
100% spunky. That is so.
Definitely. Thank you so much, Audrey. I appreciate that.
Don't go away. We still hope there have not been any questions, beautiful comments, but we're still waiting for the questions. Please, if you want to ask a question, put it in the chat. We'll love to hear about it. Now it's my absolute privilege to introduce Dr. Sage Balti to you. She's a respected leader in the field of oncology social work and serves as the Chief Philanthropy Officer and President at Innova Health Systems in Washington, D.C. metro area. She joined Innova in 2004 as an oncology counselor, and previously served as Executive Director of Life with Cancer and Patient Experience for Innova Shah Cancer Institute. She was recently recognized as a fellow in oncology social work for her career investments and achievements. And Sage dissertation explored the sexual self of young adult survivors as compared to their healthy peers. And that is very interesting. And is nationally, and I must say internationally, recognized for her expertise in sexual health and cancer, and has contributed to many books and peer reviews of journal articles. Sage is going to talk to us about assessing and addressing the sexual self of childhood cancer patients and survivors. Sage, thank you so much. I really took a wild bit when I called you, and thanks for answering that call and being on this webinar today. So Wayne, will you please allow Sage to share screen? Sage, over to you, and welcome again.
Wonderful. Thank you so much. I'm going to share my screen right now. And let's make sure we have it. Actually, let's do this one. I'm going to share screen here. Share. All right. Is it up?
100%. That's beautiful.
Okay.
Thank you.
Wonderful. So first of all, I just have to acknowledge, I think we could just turn this over to Spunky and Steven for the rest of the time to inspire and encourage each of you. I don't know who is on with us this evening, but I am really privileged to be here from the United States, and love that we have this tool called Zoom that allows us to connect and share information. I want to just preface this by saying I typically can talk for 3 to 4 hours on this topic, so I'm going to do my best to be as concise as possible. And I developed these slides more towards the healthcare professional, but for those of you who are survivors or partners of survivors or parents of survivors on this webinar, I hope that the information for you is applicable for you to take back to your healthcare providers or to reach out to a specialist and ask some questions. But please feel free. There is no question that is inappropriate or will make me blush or will be uncomfortable for me to address. So please feel free to put questions in the chat. Again, I've been a certified sex therapist for about 15 years, and this is a passion for me. You know, we know that there's ongoing challenges related to addressing the sexual health of young adults. And I know fertility is a major topic, but I'm going to have to really focus just on sexual function and sexual self in order for us to get through the talk. I have nothing to disclose. No one is paying me to do this. This is my own thoughts, my own thinking based on research and experience. What I hope we walk away with is a better understanding of this term, the sexual self, to look at maybe a little bit of the research. There isn't a lot on sexual self and specifically pediatric and young adult cancer survivors. And perhaps for those of you who are professionals in the room, give you at least 2 ways that you can walk away from this webinar to begin the conversation, if you aren't already, with your parents, with your patients or their parents on sexual health and sexual self. Part of the challenge is that there's very little literature still. So the research I did that compared the AYA, so they had to be 15 to 40, and within 3 to 5 years post-diagnosis is kind of how I measured. I'm sorry, 3 years post-diagnosis up to however long after. And looking at their peers, there was substantial changes, but some of the differences were age. Somebody diagnosed at 15 had a very different experience in their sexual self than somebody diagnosed at 29, or somebody that was 16 and had been sexually active and had a sense of their sexual body prior was different than a 16-year-old who hadn't been sexually active prior to their cancer. So again, being able to ask those questions, glean information from our patients is really important. I share this quote because I think it's really important to use the voice of survivors. I guess side effects of post-treatment, like in my specific case, I had a bone marrow transplant 3 years ago, and I've had transplant rejection issues called graft versus host. And I'm being treated for that. So I guess it's introducing a lot of physical limitations in terms of the flexibility and my skin. My skin is very tight. So, you know, I mean, just trying to bend in certain positions sometimes is impossible, or my skin feels like it's going to rip. So, I mean, I'm talking, like I said, I'm talking physical limitations around sexual health is basically the main thing that cancer introduced for me. But it's not all introduced. I suppose some mental limitations as well. Well, obviously the physical limitations are, you know, like hammering down on my mental state of mind because, okay, I can't perform, you know, because of this, this, and this. And so, I mean, it's bogging me down. Like emotionally, sometimes I don't even feel like trying. And this was a young man who, you know, was a few years out post-transplant, was in a partnership, and had recently tried to become sexually active with his partner. Again, they were in their early 20s, so he was around 17 when he was diagnosed. And his partner was threatening to leave him because he wasn't able to perform in ways that she wanted. And it was really hurtful and harmful for him, not only physiologically, that it hurt to be sexually active because of the positions he needed to be in, but it also is emotionally incredibly challenging for him to deal with the trauma that he experienced in his cancer, the trauma he's experiencing physiologically, and then be able to explain that to his partner. There was real challenges. So as providers, you know, the physiological challenges that we sometimes overlook as just, let's treat this side effect, right, GVHD, if we're not thinking about the humanness and the sexual impact of those things, dry mouth, for example, you know, it is really hard to kiss or make out with someone with a really dry mouth. It doesn't feel good. Usually there's bad breath involved. And if we're not having those conversations with our younger patients, they may not understand the implications of that, or they may feel even worse after they begin to try. And then somebody makes a comment like, ew, or what's wrong with you? Because the reality is adolescents usually don't have a filter. So they're going to say things that maybe a 30-year-old might have a little more tact in addressing. When I talk about the sexual self, I think it's important you understand because I'm a social worker, I come at things with a very holistic psychosocial perspective. So in thinking about how do I test for changes, distress in the way people's sexual function I really thought it was more than just, does he get an erection or does she have an orgasm, and more about how do things get interpreted from a very traumatic experience, then how does that affect the way they feel, their sexual feelings? How does that, or their sexual thoughts about their body, how does that affect their sexual feelings? And then how does that affect their sexual behavior? So if I come into cancer and I am 8 years old, hopefully I've had no sexual experiences. And maybe I've had some really positive people in my life who have shown me that, you know, no matter what I look like, I'm going to be okay. And so at 12, when I'm done with treatment and I'm entering adolescence, and maybe I have some extra weight because of the treatment, maybe my cheeks are a little more chubby because of the treatment, but I have confidence because I have people telling me I'm beautiful, I'm great. And their ability to adapt may be affected because of that information, where if I come in and I've had, for example, a traumatic sexual encounter, or I've come in and this is the third or fourth horrible thing that's happened in my life, or I've already felt down about my body, that outcome could be very different. So again, thinking about how they interpret the experience of cancer, even a simple scar. I remember a young woman had a port scar that had a keloid. She was diagnosed when she was 13, and that keloid was so consistently traumatic for her. That raised scar consistently reminded her that she was broken. And again, she wasn't broken, but her interpretation of that scar had massive implications on her willingness to be intimate with herself or anyone else. One of the important things as we are providers to remember is everything we do and say is watched. Everything we do and say has impact. So if we make an assumption about someone's gender based on what we observe, and that person doesn't identify, we could sever that relationship, or at the very least, create some shame or challenge. So as we are assessing our patients and their partners or their family members, thinking about language is really important. And a reminder that sexual identity, gender identity rather, is in the mind, how we view ourselves, what we think about ourselves, how we see ourselves. That gender expression is the way we dress ourselves, things we dress. I may, you know, put a hoodie on one day and some gym shorts, and the next day I might wear a really feminine dress. Everybody has that expression of themselves. The biological sex, right, that femaleness or maleness, often assigned at birth, again, can have some fluidity, but attraction and gender and sexuality all can be very fluid. And oftentimes in medicine, we want a box to check that puts them in something that is very specific. And that can be really hard. So be mindful about even having conversations. If you have a 12-year-old who identifies as a male and has a penis, so cisgender, that at 16, as they go through puberty, that may change. And we as providers need to be willing, able, and open, curious to create conversation around their sexual bodies, their sexual self, while keeping in mind cultural and religious considerations, and also knowing our laws and policies around parental consents. Here in the state I currently live in, I can have a conversation around sexual health and birth control with any child above the age of 14 without a parent in the room. Those below that age, I have to have parental consent or have a parent in the room. So again, conversations with a parent in the room versus not would look very different. Also having conversations early and often. You heard from Steven, you know, he didn't really know until much later. Had we had the courage as providers to encourage early and often conversations, so at assessment, you know, a year out, at 2 years out, as he got older, to continue those conversations around sexual health, around fertility, maybe that could have been avoided and he would have been more empowered with information. But most importantly, with the amount of loss and changes that our young patients face, it's really important to empower them and remember that their mind is often usually cancer doesn't affect the mind, and that we can heal and create change, and that the mind is honestly the most important sex organ, that we can think sexy thoughts and then feel sexy feelings, and that is possible no matter what has happened to our physiological body. Just at a high level, a few of the things we do know, and this is from adults, so 15, 16 and above, where we see those saying, here are the things that create the greatest distress for me, or the sexual challenges that I've faced. There are young men who have experienced erectile disorder or premature menopause for those who have a vagina or identify as a woman. The lack of subjective pleasure. Again, sometimes we don't realize when nerve damage happens, or when there is swelling, or when there's scars, that those areas, especially if they're near a sex organ or they affect a sex organ or they affect the way the person feels about themselves, that can have a significant impact on the sexual function of that individual. And we've heard body image and low self-esteem challenges and how that can impact the way that one views themselves, and then the way in which they're willing to go out and try dating or be in a relationship or be willing to be vulnerable and open about some of their fears, especially that first instance when they're having to reveal to someone they're attracted to the changes on their body. The other challenges people identify are not just with impaired sexual arousal or desire, but also orgasmic dysfunction in both those who have a penis as well as those with vagina. And they can change, again, depending on medications we prescribe. There may be additional comorbidities. If we prescribed an SSRI, that certainly can have a negative impact. And as we think about these, we always want to keep in mind that how we have these conversations certainly need to be developmentally appropriate. The conversation I would have with a 6-year-old about their body and the changes in their body would be very different than a conversation I would have with a 15-year-old. And so knowing how we communicate, knowing how we talk about body, about safe touch, about understanding the changes in our bodies are really important. The other thing I want to point out is some of those who were in my study had not been sexually active prior to their cancer diagnosis. And so, especially for those who identified as women or who had a vagina, there is still this idea that having sex for the first time hurts for young women. And many of them commented they didn't realize it wasn't supposed to not hurt every time. And that was because they didn't have the information and they hadn't been sexually active prior to know that it should not hurt on a regular basis. And so many of them said they just kind of sucked it up and thought that was normal. So again, remembering that if they don't have experiences to base it off what normal is, it's going to take a lot more education and a lot more questions on our part as the providers. I thought this was really powerful as well. One of the qualitative comments in the research was for us as providers to remember how significant how we show up and how we touch is to those that we treat. So this came from a young woman. When the doctors poke and prod you, that's really actually an intimate thing to be doing with somebody who you don't know, have no relationship with, but you're developing this kind of crazy relationship with this person who has a lot of control over what they're going to be doing to you, either cutting you up or going to look at you intimately, she said. And I think that has affected my sexual intimacy in a lot of ways, in that I kind of don't trust people, So I think in getting to know this young, really amazing woman, the doctors and nurses and clinical team, they weren't insensitive. They were doing what they did. They came in, they examined her, and talking to her further, what would have made such a difference was just talking to her about why they have to touch, talking to her about how this is going to feel uncomfortable. And I want you to feel empowered to say, I need you to stop, or I'm not comfortable with that right now, or I don't want to wear a gown right now. Because how we touch them can influence how they receive touch in the future. And we have the power and the ability to show gentle, kind touch. In fact, for many of our patients who are isolated in transplant, we may be the only touch they have for weeks or months. So keeping that in mind too, that how our touch, our interactions are incredibly powerful and important. We know, and actually some of this has been already commented on and spoken to in previous webinars, we certainly know some of the long-term influences on the aspects of the sexual health that can be, many of them are psychosocial. Missed or delayed milestones, whether that's growth, whether that's things like, in the United States, we have a thing called prom that all 11th and 12th graders or juniors and seniors go to, and it's this kind of rite of passage, and missing it is really hard. Maybe they missed their 6th grade. For us, that's elementary school graduation. Also, we know for some that have either pituitary gland impacted or radiation on the brain, that there might be some stunted development, Some say that chemo brain can last a really long time and affects their confidence in their learning. And when confidence is challenged outside of the sexual body, that can influence how they feel about their sexual body. So again, thinking how those normal side effects can impact somebody's view of oneself, body image, and sexual self is really important. We also know that it's not uncommon, especially for adolescents, to begin to show high-risk behaviors to kind of compensate for lost time. So they may be drinking more, they may use drugs, they may be very sexually active and not using protection, which is another piece that I think some healthcare providers are uncomfortable talking about. But if we don't give the information that not using protection could put their body at risk or maybe put them in the hospital because of infection risks, if we don't talk about pregnancy risks, we're not giving them all information. So are we truly giving them informed consent? And then as I read from a survivor before, we know that transplant survivors just have greater risks in general. The vaginal GVHD is now a known risk. The isolation that they experience can affect dating, can affect intimate relationships, can affect intimacy with themselves. And again, the longer term effects are greater. And we know again that as we have these conversations with our patients, that if we're not continuing to just prescribe, but continue the conversation or connect to counseling, we're not actually solving for the problem. So this young man talked about how he feels like he has become dependent on Cialis because he's so anxious that he can't get an erection. So he says, I totally know about that cycle, about physical discomfort affecting my mental state, especially when entering a new sexual relationship with somebody that I wasn't already comfortable with. And then, of course, once the emotions get into that affects the physical part of it. So it was like a cycle where, you know, it was really something that was difficult to get over. And in fact, I'm not sure I have. And now I keep going back to my doctor, my trusty doctor, for the Cialis prescription. So that's something I'm still dealing with now. And, you know, as we dug a little deeper in our conversations, some of that was his own insecurity about understanding other ways to improve an erection, or that maybe he didn't need to have the erection he thought he did in order to sexually please his partner. And had there been a little more questions, maybe a referral to a sex therapist or a counselor, there could have been a good few years that he could have been building his own confidence and working on his anxiety. So all of that to say, what's out there for you as providers to begin this conversation? And you can have these slides. There are lots of questionnaires you can use and integrate. The two I really want to just hope they latch on to you today, if you don't hear anything else, is, and it's a little bit of a soapbox for me, and I know Audrey's heard this from me before, but as providers, if we are not asking our patients, no matter what their age, and again, we need to understand the laws, if there has been any unwanted touch, previous sexual assault, molestation, or a trauma history of any kind, we could be further traumatizing them unintentionally, even with as simple as asking them to get in a gown or touching their chest. And it is critical for our ability to care for them, especially given the percent of people in the study I did who had had some form of sexual trauma prior to the age of 18. I was astounded. So making sure that we're asking those questions so we can treat them. And if we need to wait until they're a little older to continue asking, but think about how you might integrate that into your care. And then can you just begin to ask the question over the past 3 months, if you're seeing a survivor, over the past 3 months, how satisfied have you been with your sexual self? How sexually satisfied do you feel overall? It's a very basic question, and it asks for more than a yes, no. But it can be very disarming. They may get a little embarrassed and be like, oh my gosh, no, I'm not talking to you about that. But they may say, you're the first person who's ever asked, and here's what I'm experiencing. What I can tell you is if you ask it on a regular basis, you become the person they trust they can come to when something is wrong. Additionally, what you've just done is normalize that sexual challenges can occur in anyone, regardless of a cancer survivorship diagnosis, and that you're a person they can come to and that there's solutions. So we can do that through integrating the explicit model, which is giving permission at every encounter, during treatment and after treatment, again, age appropriate. And that might sound like, you know, here at Inova, your sexual health is really important to me as your provider. So I'm going to ask you along this journey if there's any questions that you might have, or if you're having any changes or notice any changes in the way you feel about your body or sexual intimacy. That's it, right? We're just giving permission. And what that does is it seeks permission for the patient, but it also gives permission to the provider. Or I'm sorry, it also gives permission for the person to be sexual. Then we're giving limited information, a quick sheet, specific suggestions, which take a little bit more time, and intensive therapy, which is a referral. So how might you provide those specific suggestions? First, thinking about what they already know and understand, then assessing their expectations. In this day and age, pornography is so easy to get to that, and it's so not real, that many kids, ages 12 to 19 maybe, that may be their view of what sexual function, sexuality, sexual health is. And if they think that having intercourse for 45 minutes to an hour is normal, we have an opportunity to correct that. If a young man comes to you and says, I'm ejaculating too quickly, and too quickly to them is 20 minutes, that's an opportunity. So it's also really important to assess expectations. What are they thinking? Are there other things that could be contributing? For example, for delayed puberty, the way we can address that is just educating and normalizing. Yes, providing hormone replacement when appropriate, growth therapies when appropriate are good. If there's a hormone deficiency or a potential of a hormone deficiency, checking that regularly so that you're having the conversations, you're treating it as it comes, and then addressing body image or providing body image exercise. Some quick tips on some of the main concerns that I hear as a sex therapist is for young women who are either put into protected or acute menopause with something like Lupron, where we expect that they will come out of menopause, but they still experience the menopausal side effects like hot flashes, the vaginal and vulva area are dry. And so giving them tools and tips on moisturizers and lubricants are really important. And that can be, again, on a quick fact sheet. Teaching them about vulvovaginal health. So this can be a referral to a pelvic floor therapist, but really, again, we just provide a sheet that has information on how you use dilators, the kind of lubricants you can use, and the difference between a lubricant and a moisturizer so that they can keep their pelvic floor strong for when they want to become sexually active. So if they've had radiation to the pelvic area, this may be a conversation you want to have early. And even if they're young, it might be worth an assessment to know if we proactively teach her how to stretch, strengthen, and moisturize with a dilator, will it then help her when she wants to become physically active or sexually active with herself or with a partner or partners? Other components for those who have a penis, what we find with, I'm going to just stereotype right now, men, is education is really the most important and most effective tool. Giving them the resources, making sure they understand what normal is, and empowering them that things can be adapted and changed. Certainly, if they are having any kind of erectile disorder, we are lucky that we have a solution for that. However, I would really encourage you, as you prescribe those, to also have conversations around expectations, because I could prescribe, well, I can't prescribe, my nurse practitioner can prescribe Viagra to a patient all day long. But if he isn't feeling confident in his body, if he isn't attracted to his partner, if he's feeling depressed or anxious, it's not going to fix the problem. So making sure we're assessing all of those. And then if there is continued challenges with maintaining an erection, certainly a cock ring is a great solution, and it does help for a period of time along with a penis pump. The only risk would be if they're on blood thinners, it's dangerous. So again, solutions, but make sure you're checking on any potential risks or side effects. Some additional tools for you to think about. St. Jude's here in the state actually has an incredible fact sheet on safe sex practices and sexuality and sexual health in children and adolescents with cancer. As I've mentioned, really talking about and assessing the psychosocial needs first and foremost, because if you don't assess the depression and anxiety, the sexual health is never going to improve. Thinking about, again, medications that you prescribed, if they're on painkillers, if they're on cardiac meds, if they're on steroids, all of those are also going to have interactions on somebody's sexual function and sexual health and view of self. So continuing to educate beyond just side effects and connect it to how they feel and think about themselves. Obviously, referring to a therapist or connecting to a psychiatrist can be so incredibly helpful. So as we conclude, I talked really fast and getting done on time for you, Audrey. We can start as providers offering permission. And if we do that alone, we change the way we interact with our patients. Giving them permission to be sexual beings and permission to have a conversation is incredibly powerful. Giving limited information, a quick fact sheet, a referral, specific suggestions. If you need to schedule another appointment, if somebody says to you, actually, yeah, I've really been struggling, and they begin to cry, first, provide them support, then make an appointment so you can give them the time. I know time is of the essence in healthcare, unfortunately, but we can book additional time. You can charge it as education, or put it in the patient's chart for, you know, a 30-minute education session, because that can be life-giving to that patient for somebody to actually hear them. And then refer for intensive therapy to a pelvic floor therapist, a gynae, a urologist, a psychiatrist or a sex therapist, or an oncology social worker. For those of you who are interested in learning more and maybe getting a little bit more training, the ECHO program is a wonderful resource, and you can apply for it. It's still open, and I believe they'll continue to do this program as long as people continue to register. I've had 3 of my nurses go through it, and it's been an incredible tool for them on the units. And I'll end with a quote that was written in 1985. They were way ahead of their time, and yet we still haven't seemed to learn that today the physician or healthcare treatment who treats oncological disease should no longer join the collusion of silence about sexuality any more than he should join the collusion of silence about death. Sexuality is part of life and hence part of cancer patients and their families. Thank you.
Wow, Sage. Yeah, you definitely did not disappoint me. Thank you for a powerful talk. We had a comment in, unfortunately, I can't see a lot of questions, or there are actually no questions, which is, I think, I would have loved to have more conversation. But Margaret says, she said to Stephen, thank you that we are not our disease or our cancer. And it is what you've learned about yourself that is profound and encouraging. What an inspiration. And you know what? Your talk today, Sage, makes me think we definitely need to have more honest and direct discussions. I think a lot of people are scared, maybe because of who they are in themselves, or they're shy, or they come from a different culture where this is a taboo. You just don't talk about sex or sexuality or sexual experiences, or where you don't have the guts to say, this is what I experience. And I think it is time that we and encourage our survivors and say, be open. There's a place where you can come to. I'm so glad you offered the opportunity of ECHO, and also of a place where people can learn more, because we need to learn. Because if we know ourselves and if we are confident in ourselves, our relationships will be just so much better. So I don't know, Stephen or Sarah, if you have any questions for Sage. I think it was such a powerful conversation, and we've got a lot. Oh, there's some questions. Let me quickly see what that is. Oh, Calvin said, Doctor, I had leukemia. My mother doesn't believe that I would have a child because I had radiation. What should I do to make her believe that I could get a child? That is an interesting question.
Yep. So, first of all, there are lots of ways to have children. I don't know, where you live, but in the United States, there are a variety of different ways to get children. But the first step would be what you heard from Sarah or Spunky and Steven was to talk to a physician who could test you. So if you are a man or someone with testicles, you would get your sperm tested, and they would do hormone testing as well. For a woman, they're going to do an ultrasound usually, as well as look at your hormones. So it's a blood draw, and be able to tell if you have been through menopause or not. Now, even those women who have been through menopause and maybe don't have viable eggs in order to provide for an embryo, or for those who don't have viable sperm, I don't know, because I know cultures are all different, but the United States, we have access to fertility doctors that you can get donated sperm, you can get donated embryos, and you can get donated eggs. And certainly in the United States, the only qualifier we have is you have to be 5 years post your diagnosis to qualify. And then you could carry a child. So I would say if your mother's concerned that you can't carry a child, get the information from the physicians. And then there may be other ways you could have a child and even potentially carry a child, even if you can't produce. And then certainly adoption and surrogacy are options in the United States as well. But I think, again, asking the questions of your providers and getting tested will empower you to ask the next question.
And that's where we come. We must ask the questions. And I really hope and pray that through these webinars, there's so much information, from new techniques in fertility to, there was just so much information. And I really hope that this will now ignite and spark conversation and give people the confidence, but not only the survivors, but also the medical fraternity. Give the doctors and the social workers the courage to say, let's have an open conversation. Let's talk, because at the end of the day, we need to love ourselves and to love our bodies, and then be intact with our sexual self. I can't see there are no more questions, and we are now on time. So I just want to say thank you so much to Steven and Spunky. Thanks for your guts to talk. Thanks for being so honest. We really appreciate that. And go out there and love yourself and just make good of your life, and all the survivors who are watching. And then to say, I am so thankful. Thank you so much for this very honest conversation with all the information that you gave us. I'm sure it is going to have a huge impact on the survivors who are listening. And not only the survivors, I think people in generally, man and woman, who go through struggles in their sexuality. I'm sure this talk will also be of benefit to them. Thanks again to Wayne Brown from the Brand Race for your technical assistance, and for my colleague Taryn and Musi, thank you for your help. Go out there, love yourself, and enjoy life, and be joyful in your life. Thank you so much for participating. Go well, God bless.